This was a retrospective longitudinal observational study using the data from the Mass General Brigham Research Data Registry. We looked at the use of immunoglobulin replacement therapy in patients with multiple myeloma. The time frame for this retrospective analysis was from January 1st of 2010 until February 15th of 2023. What we were looking at in this study was the use of immunoglobulin replacement therapy in patients with myeloma. We were specifically interested in seeing what the impact of using IVIG or immunoglobulin replacement therapy was on the risk of infection in patients. We know that infections are a significant comorbidity of patients with multiple myeloma. So our goals were not only to look at the use of immunoglobulin replacement therapy, but also the impact on infections and infection risk in this patient population. So, of a possible 11,000 patients that were diagnosed with myeloma, 6,062 patients were eligible from within that cohort. We excluded patients who had a prior diagnosis of primary immune deficiency, HIV, patients who'd had a solid organ transplant. We also needed patients to have had at least 3 visits within our system to be eligible to ensure that we had appropriate longitudinal follow-up. And really what we found was that of those 6,000 patients, 471 of those patients had received immunoglobulin replacement therapy at least once. And then we next looked at the interval 3 months before and 3 months after to look at the relative immunoglobulin levels and also risk of infection. Of the total cohort, as I noted, 471 patients did receive immunoglobulin replacement therapy, which was about 8% of that cohort. I think it's particularly noteworthy the time frame in which this was done. This study, came to a close before we really had significant usage of the FDA-approved CAR T-cell products and bispecifics. As I mentioned, the endpoint of this study was February 15th of 2023. And so I think what's significant about this is just that even before we had these therapies, which cause even greater degrees of hypogammaglobulinemia, we see the relevance of this information. The patients on this study, the majority, about 50% had been treated with proteasome inhibitors, 43% immunotherapies, including our monoclonal antibodies like daratumumab, isatuximab, and elotuzumab. 40% had received an immunomodulatory agent, about 36.5% alkylating agents, 34.8% stem cell transplant, 5.6% CAR T, and 1% bispecifics. And what we saw was that of the patients receiving immunoglobulin therapy, of those, about 50% received more than 2 of these administrations. And so from the time of a myeloma diagnosis to the onset of receiving immunoglobulin replacement therapy was approximately 32 months. And then what we see is in those patients receiving multiple doses of IVIG, it was an interim of about 3.1 months between those doses. And I think the most important thing that we took away from this was that the odds of infection, and particularly severe infections and antimicrobial use, were significantly lower after the initiation of immunoglobulin replacement therapy. This included all infections, all severe infections, which we defined as an infection leading to hospitalization or treatment with IV antibiotics, antivirals, or antifungals. We saw statistically significant reductions in any infection requiring antimicrobial use and also these severe infections. Beyond that, we just looked at the incidence of hypogammaglobulinemia, and particularly in patients who had multiple immunoglobulin G measurements. And what we saw was about 64% of patients with myeloma in this cohort had hypogammaglobulinemia. And what we saw is that after the initiation of immunoglobulin replacement therapy, Far fewer patients had hypogammaglobulinemia. This is not surprising, but again, this would translate hopefully into lower risk of infection within this vulnerable population. So to date, this is the largest real-world cohort study of patients with myeloma treated with immunoglobulin replacement therapy. We believe that this study provides real-world insights into the patterns of immunoglobulin measurements, replacement therapy, and infectious outcomes in a particularly vulnerable population. The takeaways are that it's important to regularly assess immunoglobulin G levels, and that IVIG or immunoglobulin replacement therapy can significantly reduce infections requiring antimicrobials, and the proportion of patients at risk.